Okay, we're going to start the next session. This is a session I've given usually over lunch hours in the past, and it's culled from actual course renal grand rounds cases at the Brigham. Every second week we have two cases shared between the Brigham and MGH in our shared fellowship program. I've not changed this talk that much over the years. I have one extra case today. And we're going to talk about two other cases at lunch, and Alan will also show some fun cases at lunch. These are not meant to be, although I've used some of them as good illustrative cases, they're not meant to be board material necessarily. So the first is a 28-year-old woman admitted with nausea and vomiting. As an aside, I think this was July 1st, so the first day of the academic year, which is not a great day to be admitted with nausea and vomiting to a teaching hospital, but that's another issue. She'd been in her usual state of health until the day of admission. That afternoon, she exercised heavily at the gym on a treadmill, much greater than her usual exertion. She took 4 ibuprofen tabs after exercising for, quote, muscle pains. She then drank 3 bottles of water, 1 liter each, out of concern that she was dehydrated. She subsequently went to a Red Sox game with family members where she drank another 3 bottles of water along with a bottle of Powerade, just for good measure. At the ball game, she noticed a headache and then she felt shaky with difficulty walking and paresthesias in her legs. She was brought to the Brigham ER by her father, arriving at 10:30 p.m. On arrival to the triage area, she vomited. On review of systems, she denied illness prior to the day of admission, specifically no prior headache, no diarrhea, no fever. She denied ingesting alcohol at the ball game, and she denied any drug use. The ER notes documented that she stated, quote, "I'm drowning," and then she stated she had made a terrible mistake. Neurology consult notes stated that she had a friend who recently died of water intoxication, so there almost was a suspicion that this might have been deliberate. Past medical history, none, in particular no psychiatric history, medications, oral contraceptives, the NSAIDs that I mentioned on the day of admission. The father has type 2 diabetes and cholesterol, high cholesterol. So in the emergency room at 1 hour after admission, she was noted to be diaphoretic, tachypneic, nauseated, and anxious, but settled down a little bit in the nursing notes and was more comfortable. On the emergency room note, physical exam, there wasn't much to find. She had tremor on finger to nose, left greater than right, and normal plantar flexion, normal dorsiflexion, whatever that is, with a hand grip 5 out of 5 bilateral. At 5 to midnight on the day of admission, her blood work showed a sodium of 121, bicarbonate of 16, serum osm 252, urine positive 3+ for ketones. This was her chest x-ray, basically unremarkable, maybe a little bit of increased interstitial markings, but certainly nothing to be too concerned about. She was given some ondansetron, and then 1 a.m. continued to shake and have nausea, and was given KVO saline but was discontinued after receipt of the blood work. She had a Foley put in, returning 180 cc's of urine. The chest x-ray, as I showed, was performed, and she was given, report was called to the floor, and she was awaiting a bed on medicine with a diagnosis of hyponatremia and water intoxication. At 3 a.m., the RN was called to the bedside by the patient's father. The patient was incoherent and twitching. This myoclonic activity escalated to clonic activity of the arms and legs, lasting around a minute. This resolved with Ativan. At 4:32 a.m., a CT head contrast, a non-contrast, showed no acute intracranial abnormality, no edema. The subsequent neurology read, as I'll show, showed some mild sulcal effacement consistent with cerebral edema. At 5:30 a.m., the renal service was called and hypertonic saline was advised, beginning at 70 mL per hour. This was Sunday, July 1st, and I was the first note in the chart. I think the neurology attending note was the second one in the chart. On my exam, she had anisocoria. Her right pupil was clearly greater than her left, with no relative afferent pupillary defect. She had a murmur and her chest was clear. So this is the CT head. You can see this sulcal effacement here, the slight blurring of her sulci, and it does look, to my mind, a little bit plump. So this is her blood work when she came in. So this is the time right after the seizure. She had a bicarb of 9. Her urine osm was 702 with a urine sodium of 124 when she presented. And after that blip in her sodium, it stayed in the mid-120s and then went up to 136 by 5 a.m. the next morning. Her anion gap acidosis quickly resolved. And of note, she started to, you could see, as I mentioned, if you follow urine osms in these patients serially, you can see how she started to have a water diuresis, coincident, of course, with her rapid correction in her hyponatremia. So the questions here, and this isn't, audience participation necessarily, but pipe up if you want. Why is this patient hyponatremic? How should she have been managed? And how should she be managed going forward? Now you're the nephrologist that's been called. So my clinical impression when I saw her was this was acute symptomatic hyponatremia in the setting of overexertion and polydipsia. I thought she had a hyperglycemic ketoacidosis in the absence of admitted alcohol intake or known insulin apnea or insulin resistance, and this clearly had resolved quickly. She also had subsequent lactic acidosis after the seizure that then resolved, I assume, which resolved quickly after the seizure. So again, we went through this, and I think this differential diagnosis of acute hyponatremia, and here we're talking really about exercise-induced hyponatremia. And this is a really excellent case in the sense that you clearly have a good history that this was less than 12 hours in duration. This is not chronic hyponatremia. This was clearly acute hyponatremia, and her behavior and everything that went along with that. So I thought there were a couple of causative factors in this case. One was the polydipsia, a marked increase in free water intake. And the acute exercise much greater than a usual activity. It's known in marathon runners that you can see a non-osmotic increase in vasopressin. And the NSAID intake, it's been shown maybe to play a role in some of the marathon studies or exercise-associated hyponatremia, but not all. That this would have caused a renal potentiation of vasopressin effects. She also had some pain, which is contributing. And again, this issue of female sex causing an increased risk of neurological consequences from acute hyponatremia. So exercise-associated hyponatremia, it's typically associated with prolonged exertion, e.g. marathons. They do get a non-osmotic increase in vasopressin that's linked partially to interleukin-6 elevations. It's also associated with excessive weight gain or water intake during the marathon. In some cases, has been associated with NSAID use, but not all. And it's the duration of exercise and the relative race time that's important, or extremes in body weight, the very thin or the very obese. So this isn't the runners that finish the marathon in 2 hours and 10 minutes. This is the runners that finish in 6 hours or 4 hours and 30 minutes and so on. And I think it's much more clearly understood now the dangers of overhydration during the marathon. Most marathons, including the Boston Marathon, have point-of-care sodiums. They will also give people hypertonic saline up front when they have a compatible presentation. In terms of the NSAIDs, this is an interesting area of physiology. If you look at rat studies, if you look at a dehydrated rat versus a hydrated rat, the hydrated rat has an increased higher than normal content of urinary prostaglandins, whereas in the dehydrated rat, you have no prostaglandins. And this correlates with the urine osmolality in the hydrated versus dehydrated rat. So in the absence of prostaglandins, even from this data, it suggests perhaps that prostaglandins do inhibit urinary concentration. And we've known this for many decades. So If I remember correctly, Allen's the Grantham professor of nephrology at Kansas, and Jared Grantham, one of his papers in the 60s, was a tubular perfusion where they looked at giving vasopressin or giving vasopressin with prostaglandins and looked at water transport across the collecting duct, and giving a prostaglandin along with the vasopressin abrogated the effect of the vasopressin. And we now know that in the thick limb and also in principal cells, that prostaglandin receptors antagonize many of the effects of the V2 receptors. So they have an inhibitory G protein that downregulates activation of pKa versus the stimulatory G protein that is activated by V2. And there are many other points in the concentrating mechanism where prostaglandins will inhibit and antagonize vasopressin effects. If you give an NSAID to a rat and look at the expression of the thick limb NACaCl cotransporter, it actually goes up dramatically. So there's a tonic suppression by prostaglandins in the thick limb of another part of the concentrating mechanism. And I talked about this, that the typical symptoms, nausea, vomiting, and a headache, are almost absolute, symptoms that are seen in all patients with acute hyponatremia that's symptomatic. And she clearly had that. This issue of she had unequal pupils, clearly that's a very concerning sign for impending uncal herniation. Whether there are other causes for the anisocoria that she had, I'm not sure, but it's definitely seen. And she had a grand mal seizure, and as you can see, it doesn't go in a nice orderly progression. She was pretty stable and then suddenly had a seizure. So this issue that I talked about in my talk, just to flesh that out, it's been shown by Carlos Arias and Alan Arief that there are two types of hypoxia in patients with acute hyponatremia. There's a hypercapnic form with no pulmonary edema where they're just obtunded and they develop hypercapnic respiratory failure. And then there's those patients with the vasogenic or neurogenic pulmonary edema that we talked about before that is due to an increase in probably circulatory permeability rather than an increase in wedge pressure. So we talked about how you should treat patients like this, hypertonic saline, and the idea that just increasing their serum sodium by 4 to 6 points is enough to get them out of trouble. And we talked about how these formulae aren't all that helpful. Well, are you concerned though about this 14 milliequivalent increase in sodium over the first 12 hours? And in this particular case, there was actually a disagreement between two nephrologists involved with this patient's care. The nephrologist that came on July 1st, I was the one covering up until June 31st, he was pretty alarmed that this patient had, quote, overcorrected so quickly. I didn't think that was an issue, and I think most people would agree with me. This is not a symptom where, this is the kind of scenario where you don't get chronic sequelae from correcting hyponatremia. But there is some opinion-based controversy here. So some authors like Alan Verbelis say, you should be cautious to overcorrect patients with acute hyponatremia. I think there's really no consequence in this kind of a setting for this rapid correction that this particular patient had. And regardless, just a modest increase in the sodium, as we talked about, is enough to get people out of trouble. So we talked about the idea of stopping the overcorrection. That's not operative in this particular patient. That's more operative in somebody who we think by history has hyponatremia of greater than 48 hours duration, where we don't want to get into osmotic demyelination. Any questions about this case before we move on? Yep. Yeah, so the hypertonic saline was given at 5:30 in the morning. And at that time, she had a sodium, she just seized. Do you have a problem with that?
Well, I guess I was taking note that the sodium was 129 at 4 o'clock when we gave
No, but we knew she'd just seized. So, and you know, I think the sodium of 129 after the seizure is probably hard. You know, there are probably other factors, and it clearly came back down to 124. So I think you'd be remiss in not giving her hypertonic saline, shooting first and asking questions later. And for this, I did use that sodium, the balance amount, and I think I usually sort of lowball the amount of saline to give, the hypertonic saline to give. Any other questions? Okay. So now for something the opposite. This is a 63-year-old Caucasian male with hypernatremia, long-term psychiatry inpatient. So this was a patient I saw at the Boston VA. We see probably, I'm sure many of you at VA hospitals see a lot of lithium-associated nephrogenic DI, which this is. This patient was intubated in ICU care, had a reported history of polydipsia and long-term lithium use for at least 4 years that we could tell from the chart. He developed hypernatremia and AKI while in the ICU with peak serum sodium of 156 and peak creatinine of 2.6. Urine sodium was measured once, found to be 157 with coincident serum osm of 318. So he'd had his water deprivation test already during his hospital admission. The history was notable for the listed problems and the medicines as listed. He's an ex-smoker, no alcohol, no illicit drugs, but he was institutionalized at another New England VA. On exam, he was drowsy, nonverbal, really not much to find on physical exam. And the blood work that we got, as shown, showed that he was hypernatremic at the time with some degree of AKI. I think that was AKI, not chronic. His urine sodium was 34 with the urine lights, and he'd had a urine output of 3.4 liters for the previous 24 hours. So the question, why is this patient hypernatremic? What is the underlying pathophysiology? What further tests should be done? How should he be managed? Well, we felt that this was a hypernatremia due to ongoing water diuresis. This is a pretty classic presentation for lithium-associated nephrogenic DI. These patients, if they're well enough, they're used to drinking a huge amount of water. When they get acutely ill and lose their mental facilities, or if they're intubated and sedated like this patient, that's when they get into trouble because of their concentrating defect. And we already knew that he'd had this concentrating defect. We thought this was a water diuresis due to lithium-associated nephrogenic DI, and he had some degree of AKI on CKD due to volume depletion. So lithium-associated nephrogenic DI, patients get NDI and polyuria. About 20 to 40% of patients treated with lithium, it correlates with the duration of therapy. Polyuria may also be due to polydipsia and or central DI, hence confirmation of NDI is essential. It also causes a chronic tubular interstitial scarring and CKD after prolonged therapy. Patients may also have a persistent nephrogenic DI long after stopping lithium. I'm sure all of us have seen that. So the pathogenesis is very interesting. That's what I thought we would talk about a little bit, because there have been some recent advances. There is a decreased density of V2 receptors. There's a classic paper from many years ago showing that magnesium could be displaced by lithium, and that would then, on the stimulatory G proteins, and then uncouple the V2 receptor from its downstream signaling. More recently, inhibition of renal glycogen synthase kinase 3, or GSK3, has been implicated in the nephrogenic DI from lithium. And this is thought to be the CNS target for lithium and its beneficial effects in bipolar disease. There's also an upregulation of medullary COX-2, again that theme from the previous case, where an increase in prostaglandins can cause inhibition of vasopressin-dependent events. So again, looking at the principal cells, you have the V2 receptor, you activate protein kinase A that activates the urea transporter, ENaC, and also the aquaporin 2 and other water pathways. After aquaporins were cloned, there was a cottage industry looking at upregulation or downregulation of aquaporins. If you look in lithium-treated rats, you basically have almost no detectable aquaporins. So you really blow out the ability to concentrate the urine by giving lithium. If you knock out the GSK3 in mice, and particularly and specifically in the collecting duct, you blunt vasopressin-stimulated cyclic AMP generation. So you see less cyclic AMP showing up in the urine, and you see less cyclic AMP in the actual papillae from those mice. And those mice get a concentrating defect, just as you see with lithium. One of the other very interesting things is sodium and lithium share many transport pathways. And lithium is actually absorbed by principal cells through the amiloride-sensitive sodium channel. So if you knock out ENaC in mice in the collecting duct, you can generate severe nephrogenic DI in their littermates that have functional ENaC, but the mice that don't have ENaC, that have an ENaC knockout, they actually don't develop a nephrogenic DI. So very clearly, you need to get entry of lithium through the epithelial sodium channel for it to exert its effects on this GSK3 and other signaling pathways to uncouple vasopressin. The $64,000 question is how much this also contributes to the chronic tubular interstitial scarring that patients get with chronic lithium over time. So many of you may be aware there were papers in the 90s. There's a famous paper from Bataille et al. And from Chicago in the New England Journal where they gave amiloride and they showed that it ameliorated nephrogenic DI in patients who had relatively recent onset nephrogenic DI from lithium. Those who'd been on the drug for a lot longer were a bit resistant, which I think is consistent with what we see clinically, where they have a chronic structural nephrogenic DI after a period of time. This is a more recent study where they looked at the maximal change in osmotic pressure after giving DDAVP, and they were able to show that you had a much better response to DDAVP in human subjects given amiloride and lithium, and that you can see a maximal density of urinary aquaporin 2, which is an indirect index of how much aquaporin 2 is getting to the membrane in the collecting duct. So my question has always been, and I'm very curious to see what people see across the country, why do more psychiatrists or why do more nephrologists not prescribe amiloride in patients on lithium? And I think that's an important question, and it's something that might be worth looking at because it is a quantitatively important medical problem in those patients on lithium. So acute management of a patient like this, first is really just watering, so repletion of both the free water deficit and ongoing free water loss from nephrogenic DI. So we went through the water deficit calculation. In his case, it was 4.2 liters. And this is usually replaced slowly over 48 to 72 hours to avoid increasing the serum sodium by greater than 10 in 24 hours, to avoid decreasing the serum sodium, by greater than 10 over 24 hours. So here, though, is the classic error I think the medical house staff will do. They're used to seeing a nursing home patient where the major problem is more the lack of water intake than it is ongoing free water loss. They'll just sort of walk away once they figure out how much the water deficit is, but forget the fact that there's ongoing free water loss. And I think us as nephrologists are used to doing this. And if you look at this patient's electrolyte-free water excretion, it's about 2.5 liters a day. So that needs to be replaced on a daily basis at the same time. So this particular patient really needed in the first 24 hours 4.5 liters at least of free water with frequent labs to make sure we don't overcorrect too quickly the hypernatremia. So the other question is, how do you manage these patients chronically? Well, I've seen many patients, most patients with bipolar disease are pretty functional, and they can do just fine by increasing their free water intake on a chronic basis. We've had some at the VA. We have a patient a long-term inpatient at our psychiatric institution. The nurses show up two times a day with 2 green water jugs and watch him drink it every day, twice a day, and that keeps him from becoming hypernatremic. The other possibilities, the polydipsia said the increased free water intake usually works. Thiazide therapy, the thought is that thiazides cause volume depletion that increases proximal water absorption. There are also some direct effects of thiazides on distal water absorption. We talked about the fact that COX-2 is upregulated in the animal models of lithium-associated nephrogenic DI. So should we get an NSAID or give a COX-2 inhibitor? The problem here is many of these patients will have CKD, and I would rarely want to give these patients an NSAID or a COX-2 inhibitor. This issue of amiloride, well, maybe we should be using this more in patients with normal renal dysfunction early on in their course on lithium, but this patient had been on it for a very long time. So the chronic management of this patient, when we thought about it a little bit more carefully, there was a lot of concern from the ICU that once he was not in the ICU and needed large amounts of free water, that he was a considerable aspiration risk. So we were asked to try to figure out a way that we could fix his nephrogenic DI and try to avoid that. So we pursued a water deprivation test, which I rarely do in these patients, but because we did, we can talk about it. So this patient, after water deprivation at 4 hours, you can see his sodium. At this time, his fluid deficit, his free water deficit had been corrected. We show that as he became hypernatremic, his serum osm went up marginally, but his urine osm didn't really respond. There was maybe a little bit of an increase. And then at about 10 hours, we gave him, 9 hours, we gave him a dose of DDAVP. We also measured vasopressin before, so this clearly was detectable, and he had not a central DI. But his urine osmolality failed to increase by greater than 50% or greater than 150 milliosms. So this is really complete nephrogenic DI. So key issues that I wanted to underline for water deprivation testing: never do it for overnight deprivation. With overnight deprivation, there is an acronym for doing the something test. I can't remember the person's name, which is basically overnight water deprivation, and I don't think we should remember that particular acronym. For patients with central DI or severe nephrogenic DI, they can get really dangerous levels of hypernatremia if they're water restricted overnight. You need to do this in a monitored setting where you're checking every hour, checking vitals and checking body weight and checking serum sodium, which is a little bit more accurate than checking osmolality and quicker. So the minute they become hypertonic, then you can look at the urinary response to that hypertonicity, then you can measure the vasopressin, and then you can give the DDAVP. Okay, any questions on this particular case? Okay. So a 50-year-old diabetic man with nausea and vomiting. So this patient works at a night shift as a maintenance worker. On the evening prior to admission, he suddenly became nauseated at work with abrupt onset of nausea and vomiting. He'd presented to the emergency room at 8 p.m. the next day. I had a recent change in primary care who had started lisinopril and metformin twice a day 1 month prior to admission. On review of systems, he denied recent gastroenteritis or diarrhea, considerable alcohol intake, several beers per night at least. He denied intake of methanol or ethylene glycol and had not been taking NSAIDs. No dyspnea or chest pain. So his meds on admission were, as we mentioned, the metformin and the lisinopril. He'd been a type 2 diabetic for 8 years, had a history of colon cancer for which he had a resection, divorced, no children, non-smoker, and a long history, as I said, of alcoholism. On exam, he was alert and appropriate, anuric, not much to really find, not particularly hypervolemic or in any kind of distress. This case actually I saw at a community hospital. It's about an hour north of Boston, where I continue to cover a private practice once a month. The ER doc called me about and said, you're just giving you a heads up, this patient can be seen in the morning. He looks fine. It's just AKI. And I said, okay, can you read out his Chem 7 for me? And the sodium was a 136, potassium 5, chloride 74, bicarbonate 15. And that's when I piqued my curiosity and decided to come in and see the patient. His blood gas is shown. He had a little bit of a transaminitis, and the hemoglobin A1C as we showed from before. So what are the acid-base diagnoses here? What diagnostic testing is appropriate? And what management should be instituted and with what urgency? Any takers before we start? So we'll see. So let's do it systematically. So my first impressions, so we'll do it one step at a time. So my impressions initially were that this was AKI due to chronic alcoholism with hypovolemia and angiotensin II dependent GFR with an ACE inhibitor on board. And we couldn't tell, he may have had some acute tubular injury, acute tubular necrosis. I couldn't confirm that by looking at his urine. He clearly had a wide anion gap acidosis. The question was, what's the etiology? He denied ethylene glycol or methanol intake. And his acidemia, it should be pointed out, is much less than expected for an anion gap of 47. So first off, is this a ketoacidosis? So his qualitative serum acetone was strongly positive. So clearly his serum contains acetoacetate and acetone. So I ordered a beta hydroxybutyrate. This came back a week later at 4.85 millimoles. So that's pretty high. So this is alcoholic ketoacidosis versus diabetic ketoacidosis. DKA is conceivable in type 2 diabetes, and it's a long subject, but there are ketosis-prone subsets of type 2 diabetes, which are called just that. But his glucose is only 137, so that's not really the issue. So clearly, alcoholic ketoacidosis is part of the problem here. And this classically presents with abdominal pain and vomiting in somebody who abruptly stops alcohol following a significant period of increased intake. And these mild abnormalities in the liver function tests are pretty common. There's a complex pathophysiology. There's a reduction in hepatic glycogen stores. There's volume depletion from vomiting. I think of this as DKA, but with an increase in counter-regulatory effects rather than the lack of insulin. There is also metabolism of ethanol that increase the NADH to NAD ratio. So this is a busy slide, but it's worth going through this a little bit. When you metabolize ethanol to acetate, you produce NADH. And if you look at the generation of lactate, that increase in NADH over NAD will tend to drive an increased production of lactate from pyruvate. The other consequence is it'll tend to drive the generation of beta hydroxybutyrate, see here, from acetoacetate. So in rough principles, the ratio of ethanol to acetate is roughly equivalent to the NADH to NAD ratio and the lactate to pyruvate ratio, and in turn the beta hydroxybutyrate to acetoacetate ratio. And we know this that in reports in AKA, alcoholic ketoacidosis, the ratio of beta hydroxybutyrate to acetoacetate is 7:1 versus 3:1 in DKA. So that's the classic finding in alcoholic ketoacidosis, is this predominance of beta hydroxybutyrate. And moderate lactic acidosis is quite common in alcoholic ketoacidosis. But in this case, the lactate is 10. So then we get to this other question, is what else is going on? And then this issue of could this be metformin-associated lactic acidosis came up. So at this peripheral hospital, they did have a screening test for metformin levels, which I'd never done before. And this came back at dramatically elevated. So therapeutic is 2 to 3 micrograms per ml. This was 18. Clearly that wasn't available at the time, but it was available about a week later. So this typically occurs in the context of CKD or AKI, but also after intentional overdose. The older incidence that people tend to quote was pretty low, but it's probably like 3 to 9 cases per 1,000 patient years. My experience has been that the people that don't get to see these patients at 2 o'clock in the morning don't think it's much of a problem. whereas the nephrologists who get called for the lactates of 30 do find it to be a problem. So metformin is excreted by the kidney and accumulates in renal insufficiency, and is classically contraindicated if the creatinine is greater than 1.4. However, we do see a fair number of patients still on metformin with CKD. It's reasonable to do dosage reductions in metformin. You could do a metformin level to make sure you're at a safe metformin level. But the cases that I've seen have been cases like this, where a patient on metformin with a RAS inhibitor gets AKI, and there's an accumulation of metformin. Coincidentally, this was the very first patient I'd ever seen with metformin-associated lactic acidosis. The next month, when I was covering the same practice, I had a patient who died with a lactate of 26 from the same scenario. So it does occur. The pathogenesis is very interesting. So metformin inhibits hepatic glucose production, but the mechanisms are actually pretty obscure. It activates the kinase LKB1, an AMP-sensitive kinase, and then that causes transcriptional repression of gluconeogenic enzymes. But you can still see hypoglycemic effects in mice that don't have that kinase. And it's known that it inhibits complex 1 of the mitochondrial respiratory chain in hepatocytes. So this is really like an uncoupling event where you're uncoupling the mitochondria from respiration. And these patients, if you look at them, they have a marked decrease in systemic O2 consumption consistent with mitochondrial inhibition. So it's not like sepsis or other forms of lactic acidosis. So classically, these patients have a high mortality, but it's much better, the survival in these patients for the degree of lactic acidosis. And you can get survival with pH less than 6.7 or lactate greater than 30. The liver dysfunction will tend to increase mortality, and dialysis is given to replete bicarbonate and remove the metformin, and that's pretty much the standard of care. So this patient was in fact acutely dialyzed that night with a drop in his anion gap and lactate during the treatment, and serial lactates remained less than 2 for the next 48 hours. So can we account for this patient's anion gap? Well, it's 47. But if we do the math, it doesn't all add up. His lactate's only 10, the beta-hydroxybutyrate 4.85. If we assume a ratio of 7:1, we get an acetoacetate of 0.7. It has been shown in metabolomics series that there are other organic anions that are elevated from the Krebs cycle. They may go up just a tiny bit, but the aggregate amount can maybe account for the deficit. But it's well described by people over the years that there's a big discrepancy between the measured anion gap and measured anions in severe anion gap acidosis. So here his pH was 7.27. The delta anion gap is 39, depending on what you define a normal anion gap. And his delta bicarb was only 9, so the delta is 4. And we therefore have a concomitant metabolic alkalosis due to his vomiting. And I think we've gone over the delta elsewhere. The principle is it's not precise, but it's accounting for changes in anion gap versus change in bicarbonate. And there are many different assumptions that underline it. But here, where you've got such a dramatic difference in the delta, it's clearly that there's a metabolic alkalosis going on. So the key points here, this is a patient who had coexistent alcoholic ketoacidosis, metformin-associated lactic acidosis, and metabolic alkalosis. We talked about the pathogenesis of MALA, and we talked about the role of renal function and the concentration of metformin and the risk of MALA and the use of dialysis for metformin-associated lactic acidosis. Any questions on this one? So I think we have time for one more case. I'm not going to use this one. This was an interesting case, though, that I wasn't involved with until clinic the next morning, where I told them to get the surgeons to see the patient immediately. But it's a case of using THAM for severe acidosis, in this case respiratory acidosis, where you don't want to increase the production of bicarbonate. I think in the 10 minutes. Okay, so this will be a quick one for the remaining time. So this is case number 7, a 62-year-old man with CKD4 and new onset of hypercalcemia. He'd been followed in the VA renal clinic since 2008. An abdominal CT in 2010 showed bilateral cysts and a solid mass in his superior right renal pole. He had a biopsy in April that was positive for renal cell carcinoma, granular and clear cell variant. As many of you know, many urologists now, some urologists are more aggressive biopsying. There used to be the question of the tumor coming along the tract that is thought not to be as much of an issue as we used to think. Regardless, at our VA, we use ionized calciums a lot, having had a point-of-care ionized calcium for many years. His ionized calcium had been 4.7 milligrams per deciliter in July of 2010, and had gone up in January 2011 and late February in renal clinic, with an increase in his B-creatinine of 44 over 2.7 to then 38 over 3.2 by February. So he was given ibandronate 6 milligrams times 1 as an outpatient with no effect on his ionized calcium. So he was given another half dose of pamidronate, again, no effect on his ionized calcium. And in fact, in follow-up 6 days later, his ionized calcium was now 6.3. He denied any excessive calcium intake. He had a remote history of milk alkali syndrome, but this was not operative this time. His CKD initially had been attributed to hypertensive nephrosclerosis or arteriosclerosis with a urine protein to creatinine of 0.2, and it's been maybe 1 to 2 over the last year. Also, he's had several episodes of AKI in the past, including milk alkali syndrome when his calcium was 16, also with hypertension and the usual VA spectrum of disorders. He's an ex-smoker, social alcohol, no IV drug abuse, and his meds are as listed. Physical exam, he always had some degree of chronic peripheral edema without much in the way of volume expansion. And he was admitted because of this problem. And his sodium was 142, potassium 5.4, chloride 106, bicarbonate 25, BUN 46, and now creatinine 4.3. He had a total calcium of 11.4. His PTH was slightly suppressed. His ionized calcium, as mentioned, was 6.3, with our range 4.5 to 5.3 is normal. His SPEP was negative. A 25 vitamin D level was in the normal range, and a calcitriol level was appropriately suppressed. So we always talk about PTH being suppressed, appropriately suppressed or not. We don't talk about calcitriol, but in actuality, the 1-alpha hydroxylase in the proximal tubule is tightly regulated by calcium and by the feedback inhibition by calcitriol generation. So in the setting of hypercalcemia, calcitriol generation should be appropriately suppressed, but we don't always get that data unless we're looking for a granulomatous cause. So his blood work showed a normal ACE level. His PTHRP was 49. The rest of his blood work as shown. So any takers as to why he's got hypercalcemia? What's that? So it's cancer. It's clearly cancer related, but do we think it's the PTHRP mediated? No. So we'll talk about why it's not PTHRP mediated. There's a trick. Regardless, his renal ultrasound is shown as mentioned. He had a DMSA scan pre-op that was pretty symmetrical. I did a bone scan because I was starting to scratch my head. Why is this man hypercalcemic? So the question was, what's going on here? He seems to have an elevated PTHRP. He has known renal cell carcinoma. Everything else was negative. And how would you manage this patient? Any takers? So first off, when we talk about managing hypercalcemia, the choice of intravenous bisphosphonate is really important in patients with AKI on CKD. So zoledronate, the three choices are zoledronate, ibandronate, or pamidronate. And zoledronate clearly can reduce GFR in patients with CKD, and it can rarely cause a very severe ATN in patients with previously normal function. And it's really contraindicated when GFR is less than 30 to 35. My experience has been that's not always universally understood by other services, and often patients with AKI on CKD will be given zoledronate, but it's not a great idea. Ibandronate's less nephrotoxic, but it's also I've used it maybe 6 times with no effect. I tend to use pamidronate, but pamidronate also can cause a collapsing FSGS lesion with a severe combined glomerular and tubular lesion. So I use a lower dose and I give a longer infusion time. All of these drugs are sort of pro-apoptotic, so the presumption is that's why they cause some degree of renal injury. But in this particular case, usually I can control the calcium with pamidronate. And here this issue of the generation of calcitriol, if you look at enzyme activity for the 1-alpha hydroxylase, you see in 2 millimolar calcium, it's inhibited within 10 hours, and you can see an activation in lower calcium. So the generation of calcitriol is very sensitive in the proximal tubule to extracellular calcium. So why did I say that this is not PTHRP mediated? Well, when they came up with radioimmunoassays for PTHRP, they noticed that C-terminal fragments accumulate in CKD. So if you use the usual assay, and in my hospitals has always been C-terminal directed, you get a C-terminal level, in this case of 49, but the N-terminal assay, which to my knowledge is only available through the Mayo Clinic, was in fact normal. So that was a red herring. So therefore, this isn't PTHRP-mediated hypercalcemia. His bone scan was negative, so this was not osteolytic. And I have to convince it to admit, at this point, I was completely stumped. So luckily, I admitted the patient, but I wasn't on service. And my much more experienced division chief, Robert Hamburger, was on service. And he immediately knew what this was. And he was chuckling that I missed this, and he's never let me live it down. And that's this issue, this association between prostaglandins and hypercalcemia in many cancers, including renal cell carcinoma. So this is one of the classic patients, and in my defense, these papers were all in the 70s. So I thought I was, at least understood that I missed this entire literature, because there's not been much since the 80s on this particular phenomenon. But clearly in this particular patient, you could see a reduction in calcium with indomethacin, and you could see this patient had prostaglandins in the tumor tissue with this therapeutic response to indomethacin. So I would not have had the guts to do this in a patient with AKI, but Robert gave the patient 25 milligrams of indomethacin TID. The ionized calcium dropped to 6.1, from 6.1 to 5 in 12 hours, with the only time I've seen an improvement in renal function from an NSAID from the administration of the indomethacin. So with a successful nephrectomy, his calcium remained within normal limits off of the indomethacin. So I think we have 2 more minutes. Want one more case if we go over a little bit? And then we'll have lunch. Okay, let me go back to... So this case, another Brigham case, is case number 6. A 65-year-old female with severe metabolic alkalosis, and she had a very unfortunate history of endometrial adenocarcinoma with multiple surgeries and many cycles of chemotherapy. It had recurred in 2009 with peritoneal carcinomatosis, and she was treated with gemcitabine and then paclitaxel. His course has been complicated by recurrent small bowel obstruction from tumor burden, eventually treated with gastric tube placement for decompression when needed. She's had 2 weeks of abdominal pain, distension, constipation, and mild nausea, vomiting ×2. She was tolerating POs at a rehab, but noted that oral contents were now spilling out around her gastric tube site. She had a normal electrolyte panel 12 days prior to presentation. Her review of systems was otherwise negative, and the rest of her history as documented there. Her meds as listed, nothing stands out. Again, on abdominal exam, she had this firm, distended abdomen, nonspecific tenderness, and she had a G-tube and an ostomy bag with drainage collecting. So her blood work, she had a marked hypokalemia with a CO2 that was greater than assay, creatinine of 2.7 from 0.8. On a blood gas, her VBG, her pH was 7.59 with an astronomical bicarbonate of 69. She did not get an arterial blood gas. They weren't able to get one. She had white count of 30, hemoglobin of 7.9. Her urine potassium was greater than assay range 90. Urine, when they repeated it, urine sodium 43, urine chloride 31, osm 455. So what's the acid-base diagnosis here? What are the acute dangers of this situation? Are you surprised by the urine chloride concentration? And how should this patient be managed? So VBGs are an interesting subject. You can use them for acid-base analysis in a hemodynamically stable patient versus in patients in shock, where you start to get this big discrepancy between VBGs and ABGs. There's several recent papers from the emergency room literature on this, but also the nephrology issue. So here, her expected PaCO2 is 74, and her expected PCO2 is 83. I confess I wouldn't probably be able to do this. I don't think of this, Winter's formula that much. I do know Winter's formula, but not the metabolic alkalosis compensation. So here she has pure compensation for a severe metabolic alkalosis. The interesting thing is that this compensation can override the hypoxic drive. So it's well described that with severe metabolic alkalosis like this, you can actually become hypoxic, which I found rather surprising. Again, this correlation of arterial and venous blood gas values, as I mentioned, with a reference. So what are the causes of metabolic alkalosis? Well, you went through this a bit in some of Alan's talks. GI loss, renal loss, mineralocorticoid excess syndromes, and so on and so forth. And severe hypokalemia is also a contributory cause, in this case, but mostly with Ks less than 2. So the typical diagnostic algorithm is shown here just for the sense of completeness. But the question here, which I found interesting, is why such a high urinary chloride when we're taught that usually with alkalosis, that's a very important key to the diagnosis of what we would normally call a hypochloremic alkalosis. Well, what's interesting is that marked hypokalemia leads to inhibition in renal tubular chloride transport with lower than typical urine chloride. And there's a classic paper from Garella et al. From Rhode Island on saline-resistant metabolic alkalosis or chloride wasting nephropathy, where these patients had marked hypokalemia. And this is one of these patients with marked hypokalemia. As they slowly increase the potassium, you can see an increase in urinary chloride with accumulated balance of potassium. So there's a terrific papers written by Gennari et al. And AJKD that go through some of the pathophysiology, but many of these chloride transporters along the nephron are downregulated in the setting of hypokalemia. So the hand waving is that, and we talked about the thiazide-sensitive transporter being regulated by that kind of interaction. So that's the hand waving in this particular case as to why the urine chloride was so high. So the management options here, massive amounts of normal saline together with potassium chloride. You can give carbonic anhydrase inhibitors, but they tend to promote K excretion by impeding proton-linked sodium absorption. Hemodialysis if patients are also hypervolemic, or you can reduce gastric hydrochloride secretion with H2 antagonists or PPIs. For those with hyperaldosteronism, spironolactone can be used. I've never seen hydrochloric acid used. It often gets trotted out as a possibility in cases like this. The important issue is this somatostatin analog, octreotide, and it can reduce intestinal secretion in gastric obstruction from 2,000 cc's a day to less than 100 cc's a day with a dose as shown. And there is also a reasonable literature about using proton pump inhibitors and H2 blockade, as I mentioned, to reduce gastrointestinal secretions. So all of these things were done. She was put on octreotide with a reduction in her gastric output from 5 liters to 2 liters. She was aggressively repleted with KCl, and I believe she was put on a proton pump inhibitor. And with those slow measures, her bicarbonate slowly normalized over the better part of a week.